thought you'd say.
Well, I've always gotten along with him,
Oh, you have?
you know, and I can text him, he can answer.
Oh.
Didn't give us the sheriff what he wanted, but he used to listen to us, and sometimes he would give us what we
Huh.
want. This guy's not gonna listen to us.
Yeah. Doesn't care.
Yeah.
Jeff, do we go by Google time or do we go by that clock?
Sometimes that clock's
Well,
only.
it's 4 o'clock.
Yeah. Google time is right, right?
Google time.
It's Bill
Okay.
Gates' time is actually what it is, right?
Yeah, that's what it is.
He owns it.
He controls more clocks than anybody in the world.
Good afternoon, everyone. Welcome to the August 9 meet. It isn't August 9.
I gotta go. I'm in the wrong place.
What is yours saying?
November 8th.
Huh.
You're looking
Okay.
at the minutes.
Here, you wanna borrow mine? I've got 2. You have the wrong agenda, probably. Welcome to the November 8th meeting.
Thank you. Glad you guys are here.
Oh, dear.
It's not August either. So we'll come to order and let's see. Sheriff, would you mind leading us on the flag salute?
Absolutely.
So it's a peril of sitting next to the chair.
Pledge. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Thank you.
A little tight.
Okay, Mr. Ferris, could you please take the roll?
Yes, sir. Thank you, Mr. Chairman. Mr. Hurlbert.
Yes,
Welcome, by the way.
Thank you. Mr. Peters.
here.
Ms. Prout.
Yes.
Sheriff Youngblood.
Here.
Supervisor Maggard.
Here.
Dr. Lyon.
Here.
Mr. Surface.
Here.
Chief Marshal.
Here.
And Mr. Miller.
Here.
We have a quorum.
Thank you very much. We're going to deal first with items on consent. This is item 4 on the agenda. Consent items are considered to be routine by staff, so they're usually voted on all at once. There are 2 items on consent today. They are items 5 and item 12. Do any members of the public have a question about either of those items? Okay, is there a motion then for us to approve our consent agenda?
So moved.
And is there a second? Second. Thank you. All in favor, please say aye.
Aye.
Aye. Is anybody opposed? Okay, we don't have any subcommittee reports today, so we'll go on to item number 7, which is public comments. Are there any members of the public that would like to address with us today anything that's not otherwise on our agenda? Okay, thank you. There are no requests for special reports from the public, so we'll go on to unfinished business. This is item number 9. Mr. Ferris, I think you're going to give us a report first. Item 9A, a report on opioid overdose data.
Yes, thank you, Mr. Chairman. I'm going to turn this report over to EMS's epidemiologist, Margaret Mize. She's going to give you a report.
Drug overdoses due to opioids have been on the rise since the 1990s. Nationally, the Midwest has seen the most significant increase in opioid use and overdoses over this time frame. Fortunately, California has avoided the worst of the opioid epidemic, ranking in the bottom 10 of all states for drug use issues. Additionally, Kern County's opioid-related hospitalization rates remain low. In 2017, an estimated 100 Kern County residents visited the ED for acute opioid overdose. However, opioid overdoses are still of concern for Kern County EMS and public health, particularly when it comes to the use of naloxone by our providers and members of the community. In 2018, the Kern County Public Health Services Department participated in a statewide naloxone distribution project. By participating in this project, Kern County Public Health acquired 984 doses of naloxone that were to be distributed to entities within Kern County that regularly interact with high-risk communities, including entities that have naloxone distribution systems already in place. The task of distributing naloxone to the appropriate entities or communities was given to the public health nursing staff. The nursing staff in charge of this project asked EMS to aid in their decision-making process by providing information about opioid overdoses in Kern County. To provide the appropriate information, we analyzed opioid overdose data from 2 sources available to us. 1, electronic patient care records, or EPCRs, from September 2017 to September 2018. All patients with a primary impression of narcotic overdose or poisoning were pulled from these dates and used for the analysis. Additionally, all EPCRs from September 2017 to September 2018 with recorded naloxone use were analyzed. Hospital discharge data for 2016 provided by the Office of Statewide Health Planning and Development. All patients with an external cause of injury related to opioid abuse were used for this analysis. The following are summaries of this data. From September 2017 to September 2018, EMS responded to 650 calls for suspected opioid overdose. Here's some information about the communities hardest hit by this issue. Of all calls received by EMS, 79% were from Metro Bakersfield and 66% were male patients. Young adults aged 20 to 34 had the highest rate of EMS calls for suspected opioid overdose. Their rate was 131 per 100,000 population. In contrast, adults aged 50 to 64 accounted for a larger percentage of opioid-related hospital discharges. Their percent was 83%. The majority of incidents for high-volume areas occurred in private residences, with the exception of Tehachapi. Most calls in this area originated from a correctional facility. From September 2017 to September 2018, naloxone was used 1,706 times by EMS personnel. Here is some information about its use and effectiveness. Of all 1,706 patients with documented naloxone use, 49% saw improvement in their status. 319 patients given naloxone were identified by EMS as experiencing a suspected opioid overdose. Of those patients, 89% saw improvement in their status. Aside from the youngest age group, naloxone administration did not differ between adult age groups. However, naloxone was more effective for a larger percentage of young adults aged 20 to 34, with 67% being effective. By participating in this project, EMS not only helped the Public Health Department to distribute naloxone to those who might benefit, but we also designed a surveillance tool for opioid overdoses and naloxone use in Kern County. This tool may allow us to detect changes in opioid abuse in our county, thus allowing us to stay ahead of a potential crisis. Furthermore, by identifying populations that are at higher risk for opioid overdoses and tracking the use of naloxone by our EMS providers, we may be able to provide public health and our communities with the information they need to prevent opioid-related overdoses and deaths. Such interventions may include education of families, users, and their healthcare providers on how and when to use naloxone. This includes increasing awareness of the California Assembly Bill AB 1535, which allows the purchase of naloxone without a prior prescription. Therefore, it is recommended the board receive and file this report.
Thank you. Any questions by members of the board before we go to the public? Any members of the public have a question or a comment about that report? How about members of the board then? I have one. Oh, Chief, you go first.
I'm curious, reading through some of this data, and we have Tehachapi listed here, and primarily the correctional facility. How do the other correctional facilities, Wasco and Delano, fit into this? Is it the same percent, or roughly the same percentage of problem in those areas?
Thank you for your question. We looked into the zip codes that had highest incidence rates, so I don't believe that those zip codes had a very high rate of opioid overdoses, so we didn't really look into that. Through our data, we had to look into, we actually had to Google map each of the incidents that we got, so that's why we only limited to the highest rates.
That's really interesting, because I would expect the prisons to be about the same across the board.
I have a question for Dr. Lyon. I took a tour and had a long conversation with the people at Aegis, which is a treatment facility for alternatives to opioids. And they explained to me, they showed me this interesting chart of when people go to the doctor, normally they take their blood pressure, their heart rate, their temperature, and a decade or 15 years or how long ago it was, they began asking, what level of pain do you feel? And when that level of pain was being introduced into that mix, that's when opioids began being prescribed on a much, much higher basis, according to them. And that was prompted, they said, by the manufacturers of those opioids, that fourth question being asked about what level of pain do you feel. Do you have you ever read much on that? Do you know much about that? And is there any chance that might change so that pain is not one of those things?
So that has been a big question for a long time for a lot of people, and there's been a lot of discussion about that. It does relate back, there's some data about Purdue Pharmaceuticals, about, I think it was OxyContin at that time, and their push, and then the pharmaceutical influence on the medical community. And so there is a lot of data to support that was added based on pharmaceutical influence. CMS hasn't really been forthright about it, in my opinion, but they say that the pain as the fifth vital sign is not required by them. It was in some of their paperwork at one point. My understanding is it's no longer technically required. But I do think, we as a society, especially in the U.S., are very concerned about pain control. We use, I think, over 80% of the opiates made in the entire world. And so it's somewhat of a cultural thing, too. And we want zero pain, and that has also influenced, how much medications people end up taking, and then more and more and more.
And as they explained to me, not only, say I was the one that was in pain, but there's the residue of that prescription stays in my medicine chest, and my children or anyone else might have access to it, and it's added to a proliferation of the product on the market.
Yeah, you're correct. And I mean, if you have had any medical procedures, because pain is such on the forefront of what has been drilled into us as medical professionals, you end up coming home with a prescription for, 30 Norco. Almost every time you have some sort of procedure, or Percocet, or whatever it may be, and some people end up taking that whole thing. Some people end up in their closet, and then you start having more, and that can also affect access by kids as well.
And that's why the prescription count exceeds population count in many communities, right? Yeah.
Chairman Maggard?
Yes.
I think it's important to give our local hospitals a little credit. When you look at the numbers for, we're lower than national average for overdoses. Our hospitals a few years ago put their foot down. And people call 911, they get an ambulance ride to the hospital because they want pain meds. And they refer them back to the primary care physician. They don't load them up at the hospital. They send them back. And one of the questions, the state of California asked in their EMS reporting program, they ask if somebody had pain, and you write yes, but you don't give them any medication, that it makes us look bad, makes the paramedic look bad for not doing that. But that's a disconnect between the data they're collecting and the reality of what's going on. But the hospital council and our local hospitals put their foot down 3 or 4 years ago.
You don't hear that story often. That's a good story to be told.
Yeah.
Yeah, and another thing we're also working on with the hospitals is trying to integrate a system called EDDI, which is a bidirectional information exchange with the emergency departments, which interconnect all the emergency departments and help alert the emergency physicians if people meet certain threshold criteria of signaling potential abuse, and automatically push the CURES data, which is the state controlled substance website that stores all the data, to the physician or the provider that's taking care of the patient, so they don't actually have to try to log in and query it. It's automatically pushed to them when the patient's registered if they meet the certain threshold.
Mr. Chairman, may I
Yes.
elaborate? Dr. Lyons is correct. CMS at one point required that question of all hospitals, and we evaluated and our reimbursement was affected by the answer to the question, did they do everything they could to control your pain? I think was, I might be paraphrasing the wording a little bit, but they recently, and I think it was just last year, took that question off because of this very issue. On the other hand, we still have all of the rating agencies, all of the patient satisfaction agencies are still asking that question. So what the hospitals are doing currently, most of them, I believe, at least the Dignity Health hospitals are, we have a program for managing patient expectation about pain. You're going to have pain after your surgery. You're going to have, I mean, it's managing to a reasonable level, not to zero. And that was kind of, you know, the general public got in their minds, I should have zero pain after all this, and that's just not possible.
But very interesting. Thank you. Okay, any other questions or comments? Then there are two issues here that both have to do with this general area, but item 9A is this we just received. So is there a motion to receive and file that report? Thank you. Is there a second? Thank you. All in favor, please say aye. Aye. Is anybody opposed? Thank you. Then 9B is state regulations regarding naloxone release.
Thank you, Mr. Chairman. This was in response to your request back in May as well. And what this is a list of legislation that California has enacted regarding the release of naloxone. AB 639 basically did several things. It protected licensed healthcare professionals statewide to release Narcan. It permits individuals to possess Narcan and administer it in an emergency situation without not having to fear prosecution for practicing medicine without a license. It also clarified and encouraged prescribers at the time to hand out and give and prescribe naloxone. SB 1438 added peace officers to the list of individuals who can administer Narcan out in the field. And you already heard a little bit about AB 1535. This basically released Narcan from prescription, and we have verified you can purchase it at CVS or Rite Aid right now over the counter without a prescription.
Very good.
And then finally, on the second page there, AB 2256 is the most recent of the laws or regulations enacted. And what that does is it adds a section 4119.9 to the Business and Professions Code, and that allows law enforcement to purchase naloxone on their own as long as they go through and provide some sort of a training program. They have to keep records for a specific amount of time, but this allows them to be able to purchase the medication and carry it without having to go through EMS. So basically that concludes this report. I just wanted to provide you with the information you had requested.
Thank you. I appreciate your responsiveness to that. Any members of the public have a question or comment about that report? How about members of the board?
And I'm sure you probably know that the sheriff's office does carry Narcan, so and that's a great thing. And some of the other agencies do, but not all of them. And I appreciate that the sheriff's office has taken that stance that this is important and is carrying Narcan.
I think we were the third in the country. We followed Hennepin County, Minnesota, and San Diego County. And I think we were the third.
Do you have any unofficial results? Has it been used very often?
Well, we've used it, absolutely. We have saves, but I don't know how many.
I've seen it used twice in my life, and it is remarkable. The results are remarkable. Okay, is there a motion then to receive and file?
Motion.
Thank you. Is there a second?
Second.
Please indicate an aye if you support. Aye?
Aye.
Aye.
Anybody opposed? Thank you. Okay, next is item number 10, which is new business. We have three items. Item 10A is ALS first responder policy. Mr. Ferris?
Thank you, Mr. Chairman. First responders are vital for a healthy EMS system, and Kern County system is no different. First responders in Kern County are made up of non-transporting agencies that respond to an emergency scene to initiate care to the sick and injured pending the arrival of the transporting agency. Historically, Kern County has had basic life support EMT first response, followed by an advanced life support or paramedic transport response throughout the system. However, there are 3 areas in Kern County that provide paramedic first response. California City, Pine Mountain Club, and the City of Bakersfield have all been providing paramedic first response for several years. In the past, the process for approving these advanced life support first responders included the creation of a new policy for each request. As a result, we have 3 advanced life support first responder policies which have created multiple conflicting response criteria. In response to these conflicts, EMS has created a single advanced life support first responder policy to replace the current policies. This new policy addresses the needs of the entire county and creates a single reference point for stakeholders wishing to become an advanced life support first responder. It removes any confusion created by the 3 older policies and creates a streamlined and clear blueprint for those entities working toward becoming advanced life support first responders. I believe that the creation of the single advanced life support first responder policy presents a significant improvement to our EMS system by providing our first response agencies a clear path to become an ALS first responder. Therefore, it is recommended the board approve the updated ambulance performance, ALS first response policy.
Very good, thank you. Any questions before I go to the public? Any members of the public have a question right on this one? Good morning. Oh, you're welcome. You're welcome. Would you mind coming forward and saying here, they record the meeting and we'll be able to hear you. And when you begin, could you just give us your name for the record?
Yes, Susan Maples from Pine Mountain Club.
He didn't want you up there just because you were praising him, but he wants you to repeat it.
He's the man that helped us get everything started 13 years ago. So. Anyway, we have Station 58 right now, which is our paramedic, and it saved my brother-in-law's life, and it saved mine years ago. And I want to know if this thing overall is it going to go back to where the paramedic covers for us, there's the whole mountain and the I-5, the one paramedic? What's that going to entail?
No, all this does is it opens up the entire county to first response agencies that want to add paramedics to their system. It's not a removal of paramedics or a removal of service in any way.
It won't take us off, because that's why people died I've lived there 30 years, and that's why people died there many years ago. We used to transport our people ourselves because the ambulance never got there.
So it adds to, it does not take away.
It adds to. It gives the public safety agencies the ability to create and add paramedics to their systems where currently they have to come and ask for a new policy to be written every time they want to do that.
I see. Oh, okay. I just wanted to know if it was going to take our guys away from us.
Oh, no.
Okay, thank you.
You okay with that?
Thank you.
Okay, you're welcome. Would anybody else like to say anything? Thanks for coming down the mountain today.
Steve Shoemaker, Deputy Chief, Kern County Fire. I just wanted to assure you that the Kern County Fire Department is going to stay up there. It's going to be up there. Our paramedics will be there to take care of the citizens up there. That's our promise to you. We've been doing it for 9 years now, and we're not planning on stopping.
So could you clarify one thing? If we're going to allow the opportunity for other communities to adopt the same type of system, is there a finite number of personnel available to provide it? And does that dilute the number of personnel available to take care of Pine Mountain Club?
I'll answer that, Chairman Maggard. We would only expand the program if we had the personnel and a reserve number of people to do it. Right now, our paramedic program is in Pine Mountain. We're looking at the Button Willow area, partnering with them, but there's no personnel and financial resources to have a paramedic in every fire station.
So if Button Willow, for example, were to open, it would not dilute the resources available for Pine Mountain?
That's correct.
Okay, very good. Thank you. Thank you. Any other members of the public have a question about that? Okay, how about members of the board? Thank you. Is there a second?
Second.
Thank you. Please indicate by saying aye if you support. Aye?
Aye.
And nay if you do not. Okay, thank you. Item number B is a against medical advice policy. Mr. Ferris?
Thank you, Mr. Chairman. The right to refuse care is a freedom that most patients enjoy in our county. On a daily basis, Kern County EMS providers are forced to walk away from patients, leaving them to care for themselves or in the care of their family. The process for refusing care is called against medical advice, and it is shortened to AMA. Unfortunately, obtaining an AMA, even at the patient's request, increases the liability for the crew and the provider companies. With community paramedic programs popping up all over the country and the landscape of EMS and the methods for reimbursement in a constant state of change, our ambulance providers may be faced with the reality of having to leave an increased number of patients at home rather than transport to the hospital in the near future. With hospitals being used more frequently for minor issues and the ever-increasing cost of an emergency room visit, Anthem Blue Cross, one of the largest insurance providers in the country, has made it known that it intends to create a pay code specifically for patients left at home and not transported to the hospital. In response to these and other changes to our system, EMS has spent many hours creating an against medical advice policy. The purpose of this policy is to provide guidelines for EMS personnel in the decision-making process for collecting an AMA. It provides a framework for determining which patients can refuse transport versus those that require transport, and if followed, could provide an additional layer of protection from liability for the provider. Additionally, the AMA policy provides for treat and refer for those patients that meet the criteria and are not requesting transport. I believe the creation of the against medical advice policy represents a significant improvement to our EMS system by providing the providers protection for whatever changes occur in the near future. Therefore, it is recommended the board approve the against medical advice policy.
Any comments by board members? Chief?
When does this policy take effect?
If approved today, it should take effect today.
Isn't there typically we don't have an attorney here, but I think there's usually a 30-day wait, isn't there? Once
For
you
a
read it.
policy enactment?
At least at my level, you have to wait 30 days. But
My question regarding implementation of this is all the EMS personnel trained in Kern County to implement this policy?
they need to be put on notice that it's.
We need to train our personnel and document that they've been trained in the policy before it's implemented.
Do you suggest that we have an enactment date that's delayed long enough so we can provide that training?
That would be my recommendation.
What do you think, Russ?
I absolutely agree that there needs to be some time. One of the things that we need to be mindful of is the documentation of these patient encounters. These are the encounters that are going to get us all in trouble, right? So we've got to make sure that the EMTs and paramedics, regardless of what agency or company they work for, they understand how to write this documentation. And, you know, when we, our complaints now, when we field customer complaints, probably a third of them are AMA complaints where somebody's upset about the way that it was documented because now they've got lawyers involved because it was an injury accident. They didn't go to the hospital and they don't like the way that the against medical advice was documented. So I would appreciate some time to make sure that we can educate all of our folks.
Mr. Peters, do you think it affects hospitals as well?
Well, typically, they're bringing people to us rather than leaving them out there. So many times we don't know if the patient has come to us, has been AMA'd out in the field. We might not collect that information. I don't have any information to support that or not.
What do you two gentlemen suggest we do? Should we?
January 1, I think, would be acceptable for us to pull it together. We could even go February 1 if you guys need more time.
What do you think, Chief?
I would like a 90-day training period before it's enacted.
That would make February 1. Would that be enough time? It's not quite 90, but close to 90.
February 1 would be fine.
One other comment.
February 1?
It- it-
You think February 1 is a good date? Sorry,
One other comment, if I could. While the report says that Anthem Blue Cross is looking at paying, there's no insurance provider right now that pays for treat and no transport. It's not there yet. Anthem Blue Cross is doing their work in Arizona right now, but it's not come to California yet. The majority of our patients, by a large number, are Medicare and Medi-Cal. That's almost 60% of our workload. And Medicare, CMS, nor Medi-Cal right now are ready to start paying for against medical advice. So the reason to have the policy in effect, looking down the road, it may be a long time down the road before treat and release covers the cost of readiness. And right now, the cost of your ambulance service is the cost of readiness, just like for the fire department or the sheriff's department. And so it's a small fraction now of patients that we're talking about. But there could be, in the end, financial implications to everybody in the county when it comes to ambulance rates. Because if you're not billing, you may go out and give Narcan or breathing treatment or dextrose, and if you don't transport them, you're no longer able to be compensated for that. Now, I do think those people should be treated and released, don't get me wrong. I think we transport way too many people to the hospital, way too many people. And the right way to treat them is at their home and leave them at home. And I know Bruce would agree that way too many people go to the hospital. Every day, 30 or 40% of the people that we take to the hospital don't need to be in a hospital. They need to be in urgent care. They need to be under the care of their private physician. And I totally agree with the concept, but just caution that Blue Cross, Anthem Blue Cross isn't going to change anything anytime soon.
People think taking the ambulance ride jumps them to the head of the queue. So what will happen, they'll triage them when they get there, and then they'll put them out in the waiting room. And they get really mad.
The number one complaint we get is people that got sent to triage. They call really angry that they're waiting in triage to be seen, and the hospitals are full, and they triage people based on their acuity, and a lot of those folks end up in triage.
We're going to hear from the public in a second, but Mr. Ferris, do you see any problem with the enactment date being February 1?
No, that's fine.
Mr. Miller, did you have a comment? Or were you just listening intently? Okay, very good. Any members of the public have a comment or a question about this item? You agree February 1? Okay, very good. So then would the appropriate motion be to, let's see, to approve the policy with an implementation date of February 1, 2019?
I believe so, yes.
So moved. Thank you.
Second.
And a second down there. All in favor, please say aye. Aye. Is anybody opposed? Very good input, you guys. Thank you. Appreciate you thinking that through. Next is item 10C, which is proposed 2019 MCAB dates, meeting dates for us. Mr. Ferris.
Thank you, Mr. Chairman. Pretty self-explanatory. The proposed MCAB dates, meeting dates for 2019 are Thursday, February 14th, 2019, Thursday, May 9th.
Was that February 14th?
February 14th.
Tell the wife we'll be home late for dinner that night.
Happy Valentine's Day. August 8th and November 14th, same time, 4 p.m. to 5 p.m. in this room.
Okay. Any members of the public have a question or concern about that? Is there a motion then?
Motion.
Thank you, and we have a second down there?
Second.
Thank you. Appreciate that, Scott. All in favor, please say aye. Aye. Is anybody opposed? Very good. Next is item number 11, our director's report. Mr. Ferris?
Thank you, Mr. Chairman. EMS has continued, to work on quality improvement by focusing on policy, procedure, and protocol changes that could provide an immediate impact in our service to the public. In 2017, EMS began a multi-pronged approach to streamline the system with intent of freeing advanced life support units from lower acuity calls, thus making them available for those patients in true need of a paramedic. This process began with the ALS to BLS handoff, allowing paramedics to hand those lower acuity patients to basic life support units for transport. Next, EMS created the direct-to-triage policy, allowing for those low acuity patients to be delivered to the triage nurse, allowing ambulances to clear the hospital and get back out on the road where they are needed. Our most recent system change was the culmination of over a year's worth of data analysis and review, stakeholder meetings, and emergency medical dispatch policy review. On Monday, October 15th, we implemented a change to the emergency medical dispatch policy for Bravo code calls. Bravo code calls are low acuity in nature, but have historically received paramedic responses. After analyzing 3 years' worth of Bravo code data, field treatment and transport data, and patient outcome data, it was determined that the vast majority of these calls represent low acuity complaints, require basic life support treatment, and thus could receive a basic life support ambulance response. At the same time, EMS launched a very comprehensive quality improvement process that includes reviewing each Bravo code call every day. While this change has only been in effect for a short period of time, it appears that it is having the desired effect in the system and providing increased paramedic ambulances to respond to those patients who truly need them. Since October 15th, we've had 1,617 Bravo code calls that have been dispatched, with 815 of those receiving a basic life support ambulance with no issues or problems noted. EMS has remained active in training and has continued to participate in hands-only CPR and stop the bleed training. During the last quarter, EMS participated in health and wellness events, emergency preparedness functions, and visited numerous high schools, training over 525 persons in hands-only CPR. Additionally, we have educated over 474 individuals in stop the bleed training. We are working with Kern Medical to reach out to schools to train as many students as possible through 2019. On October 10th, as mandated by the state EMS coordinators, EMS coordinators Charles Brockett and Nick Lidgett facilitated a tabletop exercise with a scenario of an infectious disease influenza outbreak on behalf of the Kern County Healthcare Coalition. The exercise was designed to assist the participants in interacting and communicating during a disaster. The exercise drew over 70 participants from healthcare agencies throughout the county, including urgent cares, surgery centers, doctors' offices, hospitals, dialysis centers, behavioral health, and home health care systems. A representative from the California Department of Public Health attended the event to observe and evaluate from the state's perspective. Following the exercise, she stated that no other agency had organized and presented the material in such a manner, nor had she seen as much interaction between the varied participants before. A full-scale functional exercise is scheduled for Wednesday, November 14th, during which the participants will be tested on their ability to mobilize, respond, and deploy their disaster equipment and implement their disaster plans. On November 7th, 2018, EMS staff participated in a disaster drill at Kern Valley State Prison. Staff had spent numerous hours with the prison representatives, teaching them start triage, stop the bleed, and assisting in the design of the drill. The drill was such a success that immediately following the drill, representatives from other prisons in the area approached EMS staff asking for assistance with their disaster drills. The EMS division remains focused on identifying trends and opportunities to improve the health and safety of the community and provide assistance to our stakeholders. In August, I reported to this board the status of our EMS plan appeal. The appeal centered around the state's denial of Kern County's EMS plan. Health and Safety Code 1797.254 states, local EMS agencies shall annually submit an emergency medical services plan for the EMS area to the authority according to the EMS systems, standards, and guidelines established by the authority. The last Kern County EMS plan approved by EMSA was submitted in 2006. On June 20th of this year, the State of California Commission on EMS adopted the proposed decision by the administrative law judge following a hearing that occurred in March. On August 28th, I traveled to Sacramento to sit down with the EMS systems chief at EMSA for the purpose of discussing the issues with the mandatory EMS plan. On September 21st, 2018, I submitted Kern County's 2018 EMS plan to EMSA for approval. After numerous phone calls, emails, additions, subtractions, and corrections, I am happy to announce that as of this morning, Kern County has its first approved EMS plan in 12 years. As we close out 2018 and move into 2019, we look forward to the challenges that await us and are excited about the positive changes that we will make for the citizens of Kern County. This concludes my report. I recommend that you receive and file. I'm here for any questions.
Thank you, and congratulations on having the plan in place after that many years. Good work. Any members of the public have a question or comment about the director's report? How about members of the board? Do we have a motion to receive and file then? Oh, I'm sorry, I missed that.
I just want to ask that we could continue to receive updates on the project to downgrade the ALS calls to BLS calls. I know I have experience with one that happened at Air Energy in Bell Ridge, where we had a gentleman whose leg was crushed by a walking beam of a pumping unit, and a BLS unit was sent, and we're 45 minutes just usually for the ambulance to get there. Ended up flying the patient, but I just want to make sure that we can get reports later on how we're monitoring that process.
Very good. So, well, how periodic can we receive those reports?
How periodically would you like them? We are evaluating those calls every day, so I can send you reports via email, or we can continue to report on this at the future meetings.
Do you have a preference, Mr. Miller?
At future meetings would be fine.
Okay, very good. Okay, thank you. Is there a motion to receive and file? Thank you. Is there a second? All in favor, please say aye.
Aye.
Thank you. Item number 12, we already dealt with it, was on consent. Item number 13 is board member announcements or reports. Any members of the board have a report or comment they'd like to make before we conclude today? It's 13. Then item number 14 is the announcement that our next regularly scheduled meeting is Thursday, February 14, at 4 o'clock in this room, as we just heard a little while ago. And then the deadline for submitting information about or public requests for that meeting is Thursday, January 31, 5 p.m. to the Kern County EMS Division Senior Emergency Medical Services Coordinator. So with that announcement, any other matters before us?
I have one question. On 14th February, I will not be in the county, and I do not have a backup listed. There used to be Lyle Martin, and now it's vacant. I don't know why.
Yes, I need to speak with you after the meeting. We need to, a nomination needs to be made for your backup.
Okay. Okay, any other matters before us? Is there a motion to adjourn?
So moved.
Very good, thank you. Without objection, so ordered. We'll see you on February 14th.